the G-Echo meeting. Sorry, good evening. Welcome to the G-Echo meeting. G-Echo is hosted by the Gastro Foundation in association with Project Echo New Mexico. We have our weekly meetings, and this evening the topic is pathology, and we've got Professor Martin Hale on to guide us through a few diagnostic dilemmas. Over to you, Prof. Prof.
Prof, unmute yourself, please.
Okay, right. Thanks, Dylan. Just organize myself. So we have 3 cases today, and all of them are, all 3 cases are provide an element of sort of diagnostic difficulty, really, what is actually the diagnosis. And I'll just take you through some of the sort of features that are fairly characteristic of the diseases, and also really where the problems come into play. So the first patient then is a 42-year-old woman. She had been underwent a cholecystectomy a couple of years ago, and ended up with with bowel injury and a high output stoma. And on follow-up, she's now got abnormal liver functioning and worsening steatosis. Imaging showed a fatty liver. She's been on parenteral nutrition for a while, and in fact, at the time of the biopsy, hadn't received it for a period of 4 weeks. She's had significant weight loss, going from 75 to 57 kilograms. And the liver enzymes at the time of the biopsy showed a total bilirubin of 11, with a direct of 6, an ALP of 178, a gamma GT of 584, ALT of 47, and AST of 32. She's got a total protein of 53 with an albumin fraction of 22, and the platelet count was 232. So a liver biopsy was submitted. Dylan, I don't know if you want to sort of open the discussion from a clinical point of view. It's a fairly scanty history, but yeah, 42-year-old fatty liver, and had a cholecystectomy, and then multiple bowel injuries as a result of that cholecystectomy, and now has a high output stoma. Would you like to comment at all on anything?
Sure, Prof. So I looked after her on one of the weekends I was on call. Issues at the time was she had lost a significant amount of weight quite quickly, and that would fit with the fatty liver. We weren't exactly sure why the initial cholecystectomy was performed. Was there any intraductal mischief? Was there any intraductal stones? Could some of her abnormal LFTs be due to that? Although our imaging didn't reveal any of those. She did have a hepatitis C antibody positive, but PCR negative. And she had a low positive titer of another antibody. And clinical suspicion was of fatty liver associated with the intestinal failure or intestinal failure associated liver disease, but we had a few curveballs, and hence the biopsy was performed. There was also a urge from the colorectal team because they wanted to revise one of her surgeries, and they wanted an idea as to whether this was anything, if it was all acute or if there was any chronicity with any chronic liver disease in the background. So those were the factors at the time of performing the biopsy.
Okay, so thanks, Dylan. So this is the biopsy, and So you should be able to see that.
Yes, we can.
Okay, so what we've got then, good quality biopsy. Several portal tracts are included in the biopsy, and I think at the outset, one can say that the general architecture appears to be maintained with normal vascular relationships between portal tracts and central veins. And if we look, for example, at this portal tract here, we can see that we've got all elements represented. We've got bile ducts, a portal vein, a hepatic artery or arteriole, and a minimal lymphocytic inflammatory infiltrate. In fact, very little in the way of inflammatory infiltration. But the striking pathology, as we can see, is this extensive mixed small and large droplet steatosis. You can see all this here. And I think it's probably fair to say that the extent of the steatosis, I would estimate, is probably in the region of 80%, could even be close to 90% large droplet steatosis. So I'm just trying to sort out the colors here. There are foci of steatohepatitis and ballooning degeneration. So this here, I think, is a small focus of lymphocytic inflammatory infiltration. And that portal tract here shows a little bit of lymphocytic inflammatory infiltration. In that portal tract, you can see the hepatic arteriole, the bile duct, and the portal vein. And there's a good focus there of steatohepatitis. So I'm just going to see if I can adjust the image. Because the colors are not quite right. I was using an ordinary tungsten microscope just now, and yeah, I'll just change this white balance. That hopefully will now address that. Yeah, that's better. Okay, so you can see the eosin coming through and the hematoxin. All right, so as I said, there are foci of steatohepatitis here, and I think there's another small focus of steatohepatitis, and there's also evidence right next door of ballooning degeneration of hepatocytes. So all in all, this looks like a straightforward sort of fatty liver disease, and these days we would call it metabolic associated steatohepatitis, except what we have knowledge of is the fact that she's had bowel injury, she's got a high output stoma, and she's lost significant weight. So this is not really just a straightforward case then of fatty liver disease, for want of a generic term. And what I want to do is I want to show you in some areas, and I think it's pretty subtle, but there is evidence of cholestasis, and we've got intracellular cholestasis in these hepatocytes in some areas. And I'm not sure if this is going to come across. So I think you can see here that there is a brownish discoloration, and this is actually bile that's sitting in a combination of both hepatocytes and also Kupffer cells. And if I put the diastase on, you'll see that in better detail. So you can see here in the Kupffer cells, there's considerable quantity of intracytoplasmic spheroid pigment. And there is also other pigment present in the hepatocytes. For example, down here, and this is bile. So we've got intracellular cholestasis. There's no intracanalicular cholestasis to get readily identified. Once again, we have cholestasis, intracellular cholestasis, sitting in this hepatocyte. And this is actually quite a good field because you can see that we've also got spheroid pigment as well as this intracellular bile. If we go to the Masson trichrome, one can see that we've got some central lobular fibrosis there, and I think also there. Portal fibrosis is minimal. And also minimal portal fibrosis here as well. So if we look at the history of this particular patient, given the fact that she's got this significant bowel injury, what we think this is an example of intestinal-associated fatty liver disease. And if you go into the literature, there's not too much written on this particular entity. And I think it's only really just being described, but it would seem that one of the separating histopathological features between ordinary metabolic-associated steatohepatitis and intestinal failure-associated liver disease is the presence of cholestasis. And it seems to be that, as far as I can see, is the only distinguishing feature between those two entities. There was an article that was written a couple of years ago on this, and the attempt has been to grade it, and this would be an example of phase 1. It's divided into 2 phases, phase 1 and phase 2. And phase 2 is where you start to see more extensive fibrosis with architectural distortion and progression to fibrosis. But the reason I put it on is because I think certainly I have seen, just anecdotally, I do recall patients with fatty liver disease or metabolic-associated steatohepatitis. And I think foci of intracellular cholestasis. I can't be absolutely sure, but certainly I think this is one thing that one needs to make this diagnosis. Obviously, you need the clinical history, but I mean, many patients, for example, are going for bariatric surgery these days, although, of course, with the availability of drugs such as Ozempic and those sort of drugs now, that number may drop. But I just think it's interesting that that cholestasis does seem to be one of the distinguishing features between metabolic-associated steatohepatitis and intestinal failure-associated liver disease. I know there are a couple of other histopathologists on the meeting as well. I saw Dr. Ellen Boulding's name in the attendees. I don't know if any of the histopathologists got any comment on this. Thanks, Dylan.
Thank you, Prof. So just interestingly, on admission to us, LFT reads as follows: total Billy of 22, conjugated of 11, alk phos of 240, gamma of 850, ALT of 106, and an AST of 97. Within a few weeks of nutritional rehabilitation, stabilization of the stoma output, corrections of the electrolyte abnormalities initially, bilirubin's normalized to 9 and 5, alk phos down to 166, gamma down to 430, and normalization of the AST ALT to 32 and 30 respectively. So just showing how much the high output stoma, electrolyte abnormalities, and just add to a bit of the metabolic strain on the liver that's already quite fatty in the background.
It is interesting. Ellen, are you able to hear us? I'm not sure if you're still on the meeting. Have you got any thoughts on this? Oh, has anybody else seen this entity? It seems to be a new, relatively newly identified entity. I think we've had a couple now, but I'll have another question. This is the second one I think that we've seen in about a year.
I've got 3 in the last 2 years, predominantly because our colorectal unit has started this intestinal failure clinic, and we have multiple. And it's always a dilemma because a lot of these patients have been in ICU for long periods of time, have been on TPN for long periods of time. And it's at a point where you're not sure how much maybe TPN-induced fatty liver disease versus this intestinal failure-induced fatty liver.
Yeah, it is interesting. And the other clinical aspects as well, of course, in terms of hair changes and that sort of thing that you get with intestinal failure-associated liver disease as opposed to metabolic associated steatohepatitis. Chris,
so
would you like to comment on Ozempic and that
yeah,
sort
well,
of thing?
I haven't seen this entity, but so the condition can be chronic and lead to significant fibrotic liver disease.
Yeah, they can. Yeah, they can end up with cirrhosis. Do you
And so
think
it's the cholestasis that actually is the clue.
Yeah, it seems to be that the cholestasis is one of the entities that, one of the findings that one can use to distinguish it from metabolic associated steatohepatitis. But typically, the literature talks about ductal cholestasis, which we haven't got in this particular patient. And it could well be early days. And the cases that we've seen so far have fitted clinically, but histologically have been quite subtle. So we haven't seen any cases with architectural distortion or cirrhosis yet. And Dylan, how long does it take to develop?
So, Prof, we think it's driven by so there's a group of secondary causes of fatty liver disease where it's related to severe malnutrition, rapid weight loss, those sort of things. So it can develop quite quickly in the setting of the rapid weight loss. So within a couple of months of these severely malnourishing bariatric surgeries, or these people that have been with prolonged complicated bowel surgeries in and out of ICUs with repeated relooks, it actually develops quite quickly. The quickest we've seen in a post-transplant patient develop a very fatty liver was within 2 months.
Quick.
That's quite significant, hey? And of course, I suppose the other problem is that, many of these patients will have had a fatty liver prior to their surgery.
Yes, Prof. So especially in the bariatric group of that. But the bowel mishaps, the bowel perforations during other abdominal surgeries usually had normal imaging before, and then very fatty livers post.
Yeah. Yeah, and of course, that's that subgroup of patients where you're going to be able to follow that, as opposed to those patients who are having bariatric surgery. Chris, would you like to comment on the use of Ozempic and its peers and the potential effect that that's going to have on bariatric surgery?
Well, I mean, it's a revolution, and the results are astounding. I mean, it's not just a weight reducing drug. It really impacts on the metabolic syndrome and all the comorbidities. But the big problem that we're facing, well, I don't treat these patients. I recommend that these patients go on these drugs, is the muscle wasting that's occurring. So that's going to lead to its own issues. So it's very important to, promote proteins and weight-bearing exercises when on these drugs. But the results in those that respond are quite spectacular. And yes, certainly it's going to have an impact on bariatric surgery, which has its issues as well in those that succeed in losing the tremendous amount of weight that it can do. So it is complementary. And I think for us in clinical practice, where lifestyle modification achieves probably success in 5% of patients, and then only a small proportion of those maintain the weight loss that they succeed, it's really a game changer. So I'm a great advocate of it.
Yeah,
with Oprah Winfrey and Kim Kardashian, of course.
Okay. I don't know if anyone's got any questions on that case.
I don't see
Okay,
any in the chat, Prof. Happy to move on to the next one.
all right. So the next patient is a patient who is a 40-year-old man, known to be HIV positive, and he also has hepatitis C and presented with acute decompensation. He was diagnosed with TB and was put onto therapy, and then, as one would suspect, then developed drug-induced liver injury. He had a liver biopsy that was then submitted to see if there were any other opportunistic infections. So that was towards the end of last year. Liver enzymes, so he was biopsied earlier this year, and his enzymes showed a total bilirubin of 13. He's got a direct of 9, a gamma of 1,442, and an ALP of 250, ALT of 138, and AST of 111. His total protein was 77, with an albumin fraction of 26, a platelet count of 202. So, not sure if anybody would like to comment on that. Question of hepatitis C and tuberculosis, drug-induced liver injury. Dylan, would you have any thoughts at all?
Prof, just to correct me on this one, this is Mr. A.N.
Yes.
Few more curveballs for you. So he had evidence of miliary TB on his chest imaging. He was newly diagnosed retro with a CD4 count of 5. He had PCR positivity on blood for hepatitis C virus, herpes simplex virus, and had Kaposi sarcoma skin lesions.
Yeah.
With that abnormal LFT.
Right.
So the possibility, and he had received TB treatment. So the differential on this gentleman was extremely wide.
Yeah, so we didn't get all that history at the time of the biopsy. But as you said, and we've seen these sort of patients before with multiple pathologies. And in this particular instance, was quite interesting because this is something that we come across not too infrequently. So what we've got is what I sort of call a blue biopsy. And you can see here, for example, that we've got marked expansion of the portal tracts. Sorry, I'll start again. The architecture is actually maintained. Numerous portal tracts are present in this biopsy. There is no significant fibrosis from the point of view of bridging fibrosis or septum formation. And at low power, as I said, one is left with a sort of a feeling that we've got, as I said, what I call a blue biopsy. And that is coming about because of marked expansion of the portal tracts by small round blue cells, which are lymphocytes. Oops, what's happened? No. Out of focus? No, we've got the light again. Just let's just do the alternative focus, auto exposure. I'm just fiddling around. You know, it's all very well to say technology advances things, but we've got this new microscope, and it's not great. It's got LED lights and all that sort of thing, and let me just try. Saturation is not good. Okay, let's try this. All right, so as I said, we've got this biopsy, which is shows these this marked expansion of the portal tracts, and we definitely have a problem with this. And that's frustrating, you know, because it's, you see, the other problem we have with this is the light adjusts automatically. You see, the light changes. Yeah. All right, so sorry about all this, this technology stuff. So, what I wanted to show you here, section. See, what's happening is that the microscope is adjusting the light. It thinks I've got precious eyes. So we've got this intense lymphocytic inflammatory infiltrate. We've got a bile duct there, largely lymphocytes, but in some areas, there's also a component of plasma cells. And I hope you can see it. Yes, so here we've got a plasma cell there. There are a couple of other plasma cells around. There's also a little bit of clustering of plasma cells as well. And bile ducts are identifiable. You can see here that we've got a bile duct, and it's almost being overrun by this lymphocytic inflammatory infiltrate. There's interface inflammatory activity including, I think, occasional participating plasma cells. And if you look here, you can see that we've got a plasma cell which is sitting in the interface region in amongst the hepatocytes, and I think more plasma cells around here as well, plasma cell, certainly there and there. So that then raises the possibility is, could this be an autoimmune hepatitis? Well, we know that the autoimmune markers are negative. I can't remember if the IgG was elevated at that particular time. And if we make the assumption and say that the IgG was elevated, because certainly this does happen in some of these patients that are HIV positive. We can talk about that in more detail once I've finished showing you the pathology. And then if we look in the parenchyma, what we've got is multiple foci of spotty inflammation. There are foci of hepatocyte necrosis and the odd calcium body that is being formed. But what I really want to show you here is this beading of lymphocytes that we have in the sinusoids, and that is typical of hepatitis C infection. Now, I want to come back to the portal tracts and also show you, for example, here, I don't think you can really appreciate it well, but this is a portal tract. The bile duct, in fact, has been overrun. I think the bile duct is in this region here, and there's also the beginnings of a germinal center, which you also get with hepatitis C. Now, bearing in mind that we've got a patient who's also got plasma cells in this infiltrate, you then got to think to yourself, well, could this be autoimmune hepatitis? And that's really where the diagnostic dilemma comes in, particularly if you've got a patient who's got an elevated IgG. I think the serology was negative in this particular instance. So this then is a case of hepatitis C infection, fairly typical. The only thing we don't have in this is the presence of steatosis. Often hepatitis C also shows a little bit of fatty change as well, which we're not seeing in this. But I put it to you that this is a reasonably typical example of chronic hepatitis C infection, and with a component of plasma cells. Now, plasma cells we see in patients who are HIV positive, which I find quite difficult to understand why you get this immune dysregulation. I know it's obviously an immune deficiency syndrome, but why one should get elevated or an increase in the number of plasma cells, I don't quite fully understand. And similarly, why you get this elevation in IgG often. And then, of course, also to remember that the other component, when you've got a patient with hepatitis, the other infectious agent to think of, if you have significant numbers of plasma cells, is hepatitis A. And there, for example, is a focus of spotty inflammation, and there's a plasma cell sitting in this focus of spotty inflammation. So, yeah, Denon, over to you. Perhaps we can discuss this whole question of plasma cells and HIV. Yeah, he hasn't got KS or not metastatic KS, and he hasn't got TB, not in the liver.
So, Prof, the immune dysregulation has sparked a lot of discussion, especially between us. We've now had multiple people, and the diagnostic dilemma from a clinician's point of view is that there's always an elevated globulin gap in both autoimmune hepatitis and in HIV. You may have an elevated IgG in both entities, and we have seen a few low positive ANAs at 1 in 80 where it could be either. And this makes your diagnostic criteria very interesting from a AIH point of view, at least. With regards to the hepatitis C, it has been described as triggering an autoimmune hepatitis type picture within the liver. So those features may fit very well with just hepatitis C by itself. But the immune dysregulation, the jury's out on why. We've had patients with CD4 counts under 10 with significant amount of inflammatory infiltration in the interface areas in with autoimmune hepatitis. And we've had to then initiate ARVs and immunomodulation quite closely to each other due to some patients having quite advanced autoimmune features at times.
Yeah, thanks, Dan. I mean, I certainly find it a difficult concept to understand, and I guess it's all sort of part of this immune orchestra that we all talk about. But as I said, you can get that sort of immune dysregulation with hep C as well. And I suppose the combination of hepatitis C and HIV, I guess that probably has a bit of a synergistic effect. Does anybody else have any comments on that?
Does it fit with the biochemistry?
Apologies, Prof, I lost you there.
Does it fit with does the pack fit with the biochemistry? Very high gamma GT, if I remember.
Yes.
Yes, he did
And
have
more cholestasis than necroinflammatory disease. So I wouldn't have predicted this kind of biopsy. Or do you think HIV distorts for that?
So, Prof, would have wanted to see what the large ducts look like too. Also, how much from the miliary TB point of view he had intra-abdominal lymphadenopathy or anything around the porta that could be causing cholestasis from that point of view in this gentleman. But correct, for the amount of cellular inflammatory infiltration we're seeing, this ALT at, I'm looking at his cumulative between 60 and 90, doesn't really scream what the biopsy is showing us.
There's a question from Washington. No opportunistic infections, Martin?
No, not that we can see.
His biochemistry didn't fit the typical herpes simplex hepatitis, but it would fit quite nicely with hepatitis C alone. I guess there weren't any large granulomas or any other features of a drug-induced liver injury from the TB treatment. So fitting pretty well.
And the sort of acute decompensation, do you think that was probably, because there's not much evidence of that, at the moment in terms of acute liver disease? It's more of a
we're going to put the acute decompensation in inverted commas. He was quite encephalopathic when he was sent to us initially with a very deranged LFT, and I think that's where that statement came from. But no, he wasn't in liver failure per se.
because this is the past diastase stain, and there's a fair bit of ceroid pigment in the Kupffer cells, as you can see, which is consistent with the level of hepatocellular injury. But it certainly doesn't look as though he's got acute liver failure, not from that point of view. And then from the connective tissue point of view, this is the nasal tricolumn. And quite a bit of parenchymal fibrosis in the sinusoids. So you can see this here. But it's an interesting case. And, the question of, plasma cells and autoimmune hepatitis, certainly, I mean, I've had to wrestle with this, particularly in the pediatric section, where patients have had hepatitis A infection and considerable numbers of plasma cells. And as you were saying, Dylan, with hep C, you get that quite extensive immune dysregulation as well. And the question always arises, is it autoimmune hepatitis or is it hepatitis A infection?
Yes. So, Prof. Cassanides, to answer your question, I've just pulled up his CT imaging. I've got one rim-enhancing necrotic peripancreatic lesion with extension into the portohepatis, measuring 5 by 3 by 4 centimeters, and a necrotic mass in the portocaval recess, measuring 3 by 3 by 3, with an edematous gallbladder and multiple retroperitoneal lymph nodes. So I think
Good.
we've got our gamma cholestatic answer.
Yeah, you surely have.
Yeah, so presumably those are TB masses. Would you think?
At this point, Prof, lymphoma and TB would be the top two,
Yeah.
especially since he's been on TB treatment with persistent chest X-ray features with persistent large necrotic collections in the abdomen. I'd be very concerned about lymphoma here.
And of course, with his history of KS, if he's got cutaneous KS, then he could have systemic KS as well.
Yes.
Yeah. Okay. Interesting. Were those nodules biopsy? I suppose we don't know.
To chat to his doctor, Prof.
Yeah. All right. Any other questions on him? All right, then the next patient that I've got is another gentleman who's 57 and found to have a positive ANA with a titer of 1 in 160, positive SMA with a titer of 1 in 120, an IgG of 20, a negative AMA and a platelet count of 156. And I don't have his enzymes. The submitted thoughts were along the lines of autoimmune hepatitis or metabolic associated fatty liver disease. So we got the biopsy, and it's always nice when the patients read the textbooks. As I said to Dylan and his colleagues, they should put a notice up saying, before you enter these rooms, please read the textbooks, because very, very difficult sometimes. The patient always has the last say. Anyway, so we've got a good quality biopsy. And you can see straight away that we've got these space-occupying lesions in the liver. And they are both portal-based and parenchymal-based. This is a portal tract. And you can see that we've got well-defined granulomatous inflammation. And these are clean granulomata, and they're accompanied by clusters of epithelioid histiocytes, which gives us the diagnosis of it being a granulomatous inflammatory process, together with multinuclear giant cells. And there are similar granulomata in the parenchyma. Just find them for you. So there's a nice one there. You can see this granuloma in the parenchyma. Pretty classic. It's non-caseating, as I said, or non-necrobiotic, clean looking, and a minimal accompanying lymphocytic inflammatory infiltrate. This is a portal-based granuloma. You can see that there. And there's an element of bile ductular proliferation. And native bile ducts appear to be absent in that particular portal tract. There's another granuloma there. And I want to go back. I want to go back to this portal tract here and just show you that what we've got is hepatic arteriole there. We've got this granuloma here. And first diagnosis, I think, would be that of sarcoidosis. And one of the tricks for sarcoidosis is that from a histopathological point of view, is that they show very lesional collagen deposition. And if you look at that there, the green is collagen. And I think this is a very nice example of perigranulomatous collagen deposition around the granuloma. So that's that same focus of the portal-based granuloma. But if you look in the parenchyma, got similar changes occurring in this parenchymal granuloma. You can see here, that's the granuloma, and that green represents the collagen. Now, if life was as simple as that, it would be very easy for us as histopathologists. But the problem is it's not. And I'm going to show you another patient. This is a woman who is, I think, 48, if I remember correctly. And she presented with abdominal pain, ended up being diagnosed, or she had a laparotomy, and was diagnosed at surgery to have peritoneal carcinomatosis. The biopsy was done and submitted for histology. And we came across this biopsy because the patient had a liver biopsy. We were asked to look at the liver biopsy, which unfortunately I don't have it at the moment. It's at the NHLS. Anyway, I was asked to look at the biopsy. It was called PBC, the liver biopsy. I looked at the liver biopsy and felt that it was more in keeping with sarcoidosis because they're very similar granulomata. There was a little bit of ductal involvement, but the serology for PBC was negative. Anyway, as a result of the biopsy that I'm now showing you, this biopsy was done, this peritoneal biopsy was done probably about a year ago. And what we've got is extensive granulomatous inflammation, as you see here, very sarcoidal-like, involving the peritoneum. And in some areas, if I go to this, you can see that there is an amorphous material here in the center of this granuloma, necrobiosis, but it doesn't quite have the caseous-like appearance. And in fact, there is cellular detail which is identifiable within this. For example, that sort of thing here. Now, the interesting thing is that, in fact, one of the things that you get in the liver, this is not a liver biopsy, but one of the things that you get in the liver is what we call a solitary necrotic nodule. And
Martin,
yeah,
Martin, we're losing you.
oh dear. Can you hear me now?
Yeah, better, thanks.
Okay. So one of the things that you get in the liver is a similar appearance, this granulomatous feature. We call that a solitary necrotic nodule. It was originally described, in fact, funnily enough, by a good friend of mine in the UK, Neil Shepherd, he was a registrar back in the 1980s, and he found a couple of these cases, and they put this thing together, and they call them solitary necrotic nodules, and they were called TB, and in fact they're not TB. Now, I was actually going to have a look about that, look that up again, because maybe that's what this is. But I present this to you because we've got a patient who's got granulomatous inflammation that looks very similar to this inflammation in another patient. And you can, in fact, get peritoneal sarcoidosis as well. And if you go into it, the literature actually says that it mimics peritoneal carcinomatosis. So the issue here now, of course, this patient has got or has had TB therapy, but look at these multinuclear giant cells. And they look very much like sort of foreign body or sarcoidal type giant sarcoid type giant cells. And that picture there is really quite unlike TB. But, you know, we can't always be absolutely dogmatic and say it's not TB. So I present this case to you, first of all, from a histopathological point of view, to demonstrate the perigranulomatous collagen deposition, which is said to be a useful diagnostic tip to distinguish between sarcoidosis and tuberculosis in the liver. And then just to show you the similarity between two patients, one of whom was diagnosed as TB, that's this one here, and the possibility that as she's also got granulomata in the liver, which look very sarcoidal-like. So interesting dilemma for us, and all the other investigations. Serum ACE, I think, is normal. PCR for TB was negative in this particular patient. So yeah, that just really I give it to you because sometimes you just can't distinguish between the two. Over to you, Dylan.
So, Martin, no malignancy here. This was misdiagnosed, or the clinical suspicion was one of a malignant peritoneal disease, but not. It's not.
It's not malignant. Yeah.
Okay, so it's a mimicker.
Yeah. So the differential now in this particular patient with the peritoneum is to whether to call it TB or whether to call it sarcoid. It's a dilemma. And of course, you know, you don't want to miss it first time around and give a patient who's got TB sarcoid, but it's steroids. ZN was negative, as it always is. Yeah. Pastane was negative as well. Because fungal infections such as Cryptococcus and histospasmosis can do this as well sometimes. Right, so that's...
Then how would you treat this?
Was the
Steroids
two separate
first,
ones. Two separate ones. I would actually send somebody back into that abdomen with a lap scope and ask for a proper TB culture. Because I understand there was only histology sent and formalin for that one. I'd be slightly scared with that extent of disease, liver and peritoneum. Do also want to look at the chest to see what the lungs look like before if that were to be TB, that would be very extensive TB, and high dose steroid therapy will do a lot of damage in that case. But yeah, it would start with lab scope, send it for TB, microscopy, culture, PCR, and follow with steroids shortly thereafter. But on the sarcoid note, Prof, we've had a few run of these cases recently, just diagnostic dilemmas from a physician's point of view. Sensitivity of the ACE is quoted between 20 and 80%. specificity of the ACE is quoted between 50 and 90%. So not great. We rely on the calciums, which is normal in most of them that I've seen, which hasn't been too many. We look at the other markers, IgG positive in up to 50% of cases, ANA positive in 30% of cases, IgM elevated. I don't have a stat on that one, but it's just noted that it can be elevated. So you're stuck biopsying most of them, looking at the overall pattern of disease, clearing the lungs, making sure there isn't any extrahepatic sarcoid effectively. And unfortunately, in our country, TB is still more common. So you're still most of the time chasing your tail, searching for TB everywhere.
Yeah, that's right. And you know, the problem is that, as you said, we've got to think about TB as the sort of first diagnosis when you see that, because it's so common.
Yeah, most of the time it's been the rule rather than the exception.
Yeah. And as was mentioned earlier on, IgA elevation is apparently a marker of sarcoid.
Yes.
So these are the dilemmas that, and I mean, we agonize over this, and I still, you know, in my mind, I can't distinguish with certainty whether this is TB or sarcoid. And I think what I must do is go and have a look and see if you can get solitary necrotic nodules. And as the name implies, they're usually solitary but can be multiple. And so I don't know if patients who've had solitary necrotic nodules have involvement of the abdomen. We've had a few here, and in fact, a couple of them have been able to demonstrate parasitic elements, such as ascaris and that sort of thing. So I suspect that some of them are, in fact, parasite-derived. So the worms go up the biliary tree, get stuck, and then elicit a granulomatous response.
Martin, some questions. Esau Solander saw some Langerhans giant cells.
Yeah, those Langerhans type giant cells, they're not specific. You can get those in foreign body granulomata, sarcoidal granulomata. Yeah.
And ZN was negative.
ZN's negative. Yeah, it always is. Always is.
Excellent. Thank you, Martin.
Thank you, everybody.
Pleasure.
If there's no more questions, I'd like to thank the ECHO New Mexico Foundation. I'd like to thank ECHO India for the support, and obviously the Gastro Foundation for making all of these meetings possible every week. Thank you, Professor Hale, for the lovely cases today. And Prof. Cassididis, I'm actually not sure what's on next week.
Upper endoscopy.
Lovely. We'll see you all next week.
Okay, thank you.
Thanks,
Thank you,
everyone.
guys.
Thanks, Martin.
Bye-bye.
Thanks, Dylan.
Cheers.
Thanks, everyone. Cheers.
Bye.
Thank you. Bye.